We are starting the postpartum lecture, Critical Thinking and Nursing Process of the Postpartum Client. Let's go next. So as you can see here on the slide where it says postpartum equals full service care, we are talking about everything, okay? The postpartum period is an extremely important one because of the possibilities, again, of uterine hemorrhage. It is such a focused assessment that we're going to do with that uterus to make sure that that uterus is not going to hemorrhage. So it is an important part, an extremely important part, because of that possibility of that uterine hemorrhage again, and because of the optimal period for that parent-child bonding, okay, that maternal bonding as well. So it is a postpartum is full service care. We're going to talk about all of these that you see on the slide. You follow up the uterus, the lochia, the legs, the elimination, the rest, the vaginal area, interventions, education, caring, attachments, all of this. For discharge from the hospital, usually the patients will get discharged 48 hours for a vaginal delivery and 72 hours for a C-section. Now here is postpartum vaginal care, okay? We are going to talk throughout this lecture about the postpartum physiologic changes, so we will touch up on all of these individually, okay? Just want to mention, since we're on the slide of postpartum care and vaginal delivery, that we do assess the vital signs, the fundus checks, the lochia checks, episiotomy, bonding, rest, nutrition, also at the bedside, and I did talk about this when we talked about the fourth stage of labor, which is the first to the fourth hour, 1 to 4 hours postpartum. Okay, we talked about that self-administered kit that's at the bedside. Okay, and I will tell you again that mom has a vaginal delivery, and she is, as soon as she's delivered and we've done her, every 15 minutes, we'll do her vital signs for the first hour, and we are checking fundus, the lochia, okay, all of the above. We are going to get her that self-administered medicated kit she can take herself. We'll put it at the bedside, and again, it will contain the ibuprofen, which is about 200 milligrams. She could take up to 3 tabs PO every 6 to 8 hours, and that's going to be PRN. And then Tylenol, acetaminophen, 500 milligram tabs times 2 tabs PO every 4 to 6 hours, PRN. And also Colace. Okay, 100 milligrams times 2 tabs PRN for constipation. So we want to keep her pain-free, but we don't want her to take any narcotics. So ibuprofen, Tylenol should be able to do it. Okay, and then to keep her stool soft so she's not straining to go to the bathroom, since we know that maybe she spent a little bit of time trying to deliver this baby, and with a C-section, because she's got stitches, we want to make sure that we're going to give her Colace so that it's easier for her to have a bowel movement. Same with a postpartum C-section, a little bit different, okay? We're still going to assess vital signs, but we're going to assess that post-anesthesia state, the oxygen status, because she did go to surgery, okay, the eyes and nose. Now, of course, because mom's had a section, okay, she's had anesthesia to get this baby out, to have this baby, she's going to have a Foley to gravity that's usually going to be DC'd after 12 hours. Okay, so, postpartum after 12 hours, she'll have that Foley DC'd. And then fundus checks, okay. Fundus check, she'll have her normal saline, 500 cc's with 30 units of Pitocin. That's going to run at 120 cc's an hour. And then we'll do lactated ringers at about 125 cc's an hour, okay? And this is Pitocin, this is fundus check, so this is Pitocin that's going to run, okay? And then we'll convert that to lactated ringers at 125 cc's an hour. And then we'll HEP lock mom when she's tolerating PO fluids. Okay, we'll HEP lock it. And then, of course, because she has been to surgery, we're going to maintain that IV access for 24 hours. Okay, with her lochia checks, we're still going to obviously do look-at checks on both moms, but a little different with C-section because she's been to surgery. We're going to go ahead and, just like the vaginal delivery mom, first hour after birth, okay, those first hours after birth, we're going to do fundus checks every 15 minutes for the first hour. Okay, so the first hour after birth, we're going to do fundus checks every 15 minutes. So we're going to do we're going to do look-at fundus checks every 15 minutes for the first hour, every hour thereafter for 4 hours. And then once she'll go into the postpartum unit, we'll do every 8 hours until delivery. Okay. When we're doing look-at checks, and we will talk about this again, but since we have the slide in front of us, I'm going to talk about it now as well. We're going to remove the perineal pad, okay, the pad, and we're going to evaluate the lochia. So when we do the look-at checks, we want to look for we're going to see the color, the character, the amount, the odor, okay, and for presence of clots. Of course, it's a C-section, so we'll look at incision and dressing. Bonding is very important, that relationship that baby has with that mom, okay? Maybe with the partner, the significant other, the baby's dad that's in the room as well. Rest, nutrition is very important. And of course, because it's a C-section and she went to surgery and now, of course, she's got the anesthesia, she's got to wait a little. We're going to get her up and walking as fast as we can. But we got to get, she had an epidural. We're going to get that sensation back in her legs. Cough and deep breathe every 2 hours while she's awake for 24 hours. Okay, so don't forget the incentive spirometer every 2 hours. Don't forget the coughing and deep breathing every 2 hours while she's awake for 24 hours. Then we're going to have mnemonic stockings on her until she's ambulating. Okay, and we're going to document I's and O's until that IV is DC'd, until she voids for at least 2 times. Okay, so don't forget to document the I's and O's until that IV is DC'd and she's voided 2 times. Okay, so obviously her Foley is going to be out. Her IV will be out, and then she'll void for 2 times. And then we don't have to document I's and O's anymore. And then we're going to start with our postpartum picture. And then we're going to start with our postpartum physiologic changes. So you could see how we've been talking about how this baby in utero is pushing everything up. Okay. Now, the first thing we're going to talk about is vital signs. There's a temperature increased in the first 24 hours. Okay. And that's normal. That's normal physiologic change. After the 24 hours, and when I'm talking about a temperature increase, I'm talking about 100.4. Okay. And that's normal. But after those 24 hours, that temperature, that patient should be afebrile. Okay. So that temperature should not be up anymore. The pulse is decreased because remember we talked about how the pulse is increased during pregnancy, okay, at least 15 beats per minute higher. Now that pulse is starting to get decreased, okay, so it's going to go, to her norm again. If we still have a pulse of more than 100 beats per minute, then we have to check mom for hypovolemia because remember she's got lochia, so we have to check her for hypovolemia, maybe dehydration, maybe there's some blood loss. So we've got to make sure that mom is drinking every hour on the hour, at least a little cup of water, an 8-ounce little styrofoam cup. She's got to be drinking every hour on the hour, especially if she's also breastfeeding. And even if she's not breastfeeding, she's letting the uterus is cleaning out. So she's got all this lochia that's leaving her system. And we've got to make sure that she is well hydrated. Those blood pressure pre-birth, okay, pre-pregnancy levels usually start to come back to normal with pre-birth levels by like that 4th postpartum day, okay? You can also watch out for orthostatic hypertension, okay, especially if she's hemorrhaging or she's got a lot of blood loss, that lochia. If she gets dizzy, if she gets tachy, if there's excessive blood loss, if there's inadequate fluid intake, she can start to have that orthostatic hypotension. So that's why your assessment is ideal in these mamas, especially when you get them in fresh to the postpartum unit. Okay. breast, first and second day, it's that breast is going to secrete colostrum, okay? And just a picture of a breast when they become engorged. The third and fourth day, the milk is filling in, the filling milk forms within the breast ducts. Then after that fourth day that mom is postpartum, those breasts may become engorged. So just like the Atom is a great resource for pictures. Just like the resource after fourth day, they can get taut, they can get shiny, they can look enlarged. Your book briefly goes through but a lot of the lactation consultants and all of the floors in the postpartum units, um, they keep frozen cabbage leaves and they're really good. It's homeopathic. You can put them on 50 minutes on, 45 minutes off. Great relief for engorgement, okay, for that pounding sensation in that breast. Um, Relief also could be, breast binder, like a tight bra to support. Always, we always encourage the moms when they come in to deliver. One of the things that you want to bring to the hospital is a bra, okay, supportive bra. Ice packs are also good, okay, because they have natural anti-inflammatory and an analgesic, okay. Now, right before mom is going to breastfeed again, whether that's 2.5 hours after mom is going, when she's getting ready to breastfeed again, we want to do warm compresses, okay, and that way it'll help that milk, okay, come down. But then she can do her frozen cabbage leaves when she becomes engorged, 15 minutes on, 45 minutes off. And that's for that pounding sensation. But right before she goes to breastfeed, those warm compresses are ideal. Another visual pictures is we're going to talk about the uterus. Okay, nice little uterus over here, non-pregnant. But remember, all this lining gets thinner, all this baby and everything pushes up. Okay, as you can see, the bladder sits right under. Okay, the bladder is supposed to sit right under that uterus. Okay. So talk about the uterus, we'll talk about that famous involution process, that is the reduction back to pre-pregnancy state that the uterus has to go through. You've heard me talk about involution when you go in for your skills day at school. We will talk about postpartum. We'll talk again about this so that it makes more and more sense to everybody. We're reinforcing information. So you'll hear involution again, okay? And your slide just tells you after birth, the uterus is usually between the symphysis pubis, which is at the bottom, and do a picture again. We showed this picture same when Juan was in the fourth stage of labor after she had just delivered fresh and we were assessing the uterus. So always make sure that one hand is on the symphysis pubis, okay? You never want to palpate a uterus without supporting the lower segment, okay? This lower segment right here by the symphysis pubis, okay? So one hand is going to go right above the symphysis pubis, and the other hand is going to be at the umbilicus, okay? And then this right hand that's going to be at the umbilicus is going to press in and downward, okay, within the hand and the umbilicus until you bump, okay, until you bump against a firm globular mass in the abdomen, okay, and that's going to be, okay, the top of the uterus and then right at the symphysis pubis, okay, and then we want to see the height where that uterus is at, okay, and of course, again, how we chart it, we'll do 2 finger breaths below the umbilicus for every postpartum day. So if you have a fresh mom, we'll go back to the slide. If you have a fresh mom that just came in, again, after birth, right after birth, you're between the symphysis pubis and the umbilicus. Okay, that's where that uterus is at. And then 1 hour after birth, it's going to go right at the umbilicus. And then 24 hours after, you're going to see the 1 to 2 finger breaths, okay, below the umbilicus for every postpartum day. So a fresh mom can be right on the umbilicus, which is right where you want that to be. And then with every day that she is there, okay, it's 1 to 2 finger breaths below the umbilicus. And it takes about 7 to 9 days for that uterus to involute to come fully back to pre-pregnancy state. And again, how's that fundal height assessed? We have we'll just turn into pictures again with the involution process. Okay. We want to make sure that the location is midline. The height, we do it in finger breath, so these are centimeters, so it's a finger breath. And then the firmness, the consistency. Is it firm? Is it soft? Is it boggy? And if it's not firm and it's not midline and it's, to the side, it feels like it's to the side, a little displaced, mom probably has a full bladder. And we need to make sure that before we do a fundal check, that we make sure mom has an empty bladder, okay, before we actually do that. And we want to make sure that it's firm. Now, if it's boggy, we want to make sure we do a firm fundal massage. Maybe there's a clot or two that will come out, so that to remind that uterus that it needs to continue to contract, okay, so that it goes back to pre-pregnancy state. Okay, so those first few days postpartum are very, very important. Especially if she's a fresh mom that comes in, because we know of the biggest risk postpartum after that mom delivers is the uterus. It's that focused assessment. It's the uterus. We want to make sure that it continues to contract, which are the after pains, which is this process of involution to come back to pre-pregnancy state. And it needs to be firm. It needs to be midline. Okay. And it needs to be involuting 1 to 2 finger breaths below the umbilicus for every postpartum day. And then lochia. Okay, the lochia is that uterine flow consisting of blood, decidua, white blood cells, bacteria. As the placenta is separating from the endometrium, this is all the sloughing off of everything to get that uterus nice and clean again. All that sloughing off is in the lochia. Okay, lochia is measured according to the amount. Okay, so red is rubra, 1 to 3 days postpartum. These are like heavy menses. And then you get from pink to serosanguinous, and that's the serosa. Okay, and this is about, I put about 3 days. Okay, it could happen the 3rd day, it can happen the 4th day, all the way to 10 days, pretty, give or take. And then you've got alba, the white to yellow, takes about 10 days. It may last up to 6 weeks. Okay. The pad that mom has on, we should be able to change her pad every 3 hours. Okay. So every 3 hours, she takes care of baby. She's either breastfeeding or bottle feeding, and mama takes care of her. Okay. She will wash her bottom. Okay. We have little bottles of water in the hospitals that she can wash from front to back. She can pat dry. Okay. And then what we are going to do for her is we are going to, she's going to get her pad. Okay. So we have these really fancy underwears at the hospital that we can give her. They're really big and they look like a little mesh. Okay. Right after she delivers, and we put a big pad on, and we'll wipe from front to back, and then we'll teach her how to do that the first time that she gets up, and she can wipe from front to back to the water, pat dry, and then she can go ahead and put the pad on. Then she can put on, depending on when she's delivered and how uncomfortable she's been, and we did talk about this in labor and delivery as well, and when we were doing the assessment the first 4 hours. But I'm reminding you again, since we're talking about lochia, reminding you again, and then the next one is perineum, so just want to remind you again. So when she's changing and she's taking care of herself, we'll go into our perineum, lochia checks, perineum, and she's taking care of herself. We are changing her pad, giving her the little water bottle. She can put it on from front to back. She can wipe, so pat dry, okay, from front to back. And then she can go ahead and change the pad. Then we can go ahead and she can put on a pad that's called a witch hazel, okay. She can put it on. It's a little round. It's round and it looks like a wipe, a baby wipe, but instead of being square and long, it's just a round little wipe. She can put it on. That's witch hazel, and that helps. Has witch hazel, so it helps with her bottom. If she's got hemorrhoids, it'll help her. If she's got a little bruising and ecchymosis, that will help her too. And then we could do dermaplast. okay, or Epifoam or Dermaplast. That has a little bit of lidocaine, and it will help mom in her bottom if she has a tear, she has an episiotomy, she took a long time delivering. Okay, so every 3 hours she can take, mama takes care of her, and then she can take care of baby, changes diaper, feeds baby, and then mama takes care of her perineum. Okay, her hygiene is very, very important to save her from having a big infection. Okay, so pad, okay, perineal pad. We could do a witch hazel pad, a little witch hazel, okay, a little pad, little round pad, and then we can go ahead and put Epifoam or Dermaplast, whichever pharmaceutical company that hospital has. And then she can put it on her, and every 3 hours she can change. Okay, so the soaking through a pad every hour, that means that she's losing more than the average amount of blood. So she shouldn't be soaking her pads every hour. That pad that she has on should last her for at least 3 hours. Okay. Then continuing on here with her perineum is, yes, her bottom. So tissue swelling, that's going to be normal. It's going to be tender. She's going to have some ecchymosis. Now, how do we check mom's bottom? Okay, is we want to make sure when we're going to do a perineum assessment, there are flashlights in postpartum units. Please use them. You check laying on her side, okay, and we're going to flex her upper leg. Laying on the side and flexing her upper leg. Okay, Kegel exercises are really important. They improve muscle tone. We do the perineal care. And then the labia majora and the labia minora are going to remain atrophied. They're soft. Good for circulation, good for vasodilation. Again, those witch hazel, and they're called tucks, little pads, little round pads. So that's witch hazel. It has witch hazel, or there's a tucks, and then the Epifoam or the Dermaplast, and that's what has that lidocaine that we can put in her bottom. Also, if she's got hemorrhoids from all of the laboring that she did with through the delivery, then we can give her some anti-hemorrhoidal cream, like Anusol, for example, a 2.5% cream 4 times a day every 6 hours. Excuse me. Anusol 2.5% cream 4 times a day every 6 hours, or Anusol 1% suppository, BID, PRN as needed. We could do it every 12 hours. Okay, so twice a day, BID every 12 hours. She probably wants to stay away from the suppositories at first, so we can do the cream at the very beginning. Okay, so then we're going to talk about GI system. If she does have hemorrhoids, okay, we will assess those. Due to relaxin, her bowels may be sluggish. And remember, that's the hormone that relaxes the ligament cartilage. So some nursing considerations to prevent and treat constipation. Because, pain from the episiotomy or the hemorrhoids may cause her to hinder those bowel movements. So we want to make sure she's ambulating, she's drinking fluids, at least 6 to 8 glasses, those little styrofoam glasses in the hospital. And then when she goes home, a regular 8-ounce glass of water a day. So 6 to 8 of those. She can drink apple juice. Now, apple juice contains sorbitol. And sorbitol is a natural sugar with laxative properties. Of course, trying to eat as healthy as she can to get this GI system back working. Fruits, veggies, whole grains, bread, stool softeners. That's why we're giving her the Colace. Remember that self-medicated, kit. That's why we're giving her the stool softeners, and of course the suppositories, for the hemorrhoids. And if she hasn't been able to have a bowel movement, after her 2 or 3 days, let's say she had a C-section, she hasn't been able to do a bowel movement, and she's going home, you can alleviate to make sure that she is going, you don't want to discharge her so uncomfortable. We could do even maybe a half, like a sliver, we can slice it, and we can give her a glycerin suppository, and see if she can go to the bathroom, have a bowel movement this way before she is discharged, Now, the stool softeners are really important because we want to avoid her bearing down, okay, to have a bowel movement, because that's can produce breakdown of her healing sutures, even if she had an episiotomy, if she delivered a vaginal, or if she had a C-section, okay? So straining is not a good thing, so we want to keep her from doing that. Then GU, okay, those are obviously pictures of hemorrhoids. So those little things that you see are very uncomfortable. And sometimes moms will say, you know, this was much more uncomfortable for me than even the episiotomy, okay? And that's why we want to put that Tux, which is the witch hazel, which is anti-inflammatory, which is the witch hazel, and it's going to help with the hemorrhoids. The GU system, so immediately postpartum, there's a trace in proteinuria, and then that diuresis will begin 12 hours after delivery, okay, to 1 week, and actually accounts for like 5 pounds of a weight loss. And then, of course, diuresis is a result of aldosterone production and also decrease in sodium retention. And you could see the swollen legs here since she was about 33 weeks pregnant, okay? But then she delivers, and that diuresing process will start, okay? Now the skin, so we're actually doing pretty much a head to toe with the postpartum, okay? And all these normal physiologic changes that are happening. So usually about a week after mom delivers, she's going to experience muscle aches, strains as a result of all that exertion that she's done during labor. So stria, which are stretch marks, okay, that's all part of the integumentary system. They're going to appear a little bit more reddened, more prominent. They will fade into pale white or darker pigmentation, depending, okay, that hyperpigmentation of the skin. And that's the linea nigra, that's a black line, okay? That will eventually disappear. White line will disappear, we said it, as postpartum hormone levels peak down, then that will start to disappear. And then the chloasma is that excessive hyperpigmentation on the face and the neck. And that's with the effects of estrogen and progesterone that has happened throughout the pregnancy. So as those levels climb down, mom will have less and less of that showing. It may persist in some moms because they're taking birth control pills and they do have the hormones. Okay, just want to show you what stretch marks look like. This is at 38 weeks when this mom was pregnant. You could see all the stretching. Okay, and then 2 days postpartum, how they kind of turn into that pale white or like a darker pigmentation. Okay, and then of course the black line, okay, in relationship to how big the baby is in utero. So 20 weeks, 22, 24 as it grows, okay, up to the fundus, and then the chloasma. Okay, so a little bit on postpartum psychological changes. Okay, so these psychological changes, there's factors that influence adaptation to parenthood. Okay, we know that becoming a parent creates a period of change, a period of stability for men and women who decide to have children. Factors. Age is a factor. Culture is a factor. Socioeconomic levels are factors. Expectations of what that child would be like. It's also factors, okay, that influence the adaptation to parenthood. And Reba Rubin was a nursing theorist, okay? She identified phases that postpartum women go through in the process of them identifying themselves as a mother, okay? And that taking in phase, it's that dependent phase, the phase that they're still excited, they're talkative, they have a desire to review the birth experience. Then there's a dependent-independent, which is the taking hold phase. This is the phase that lasts about 3 to 10 days. This is about mom already starting to take charge. And you will see this. And then there's this interdependent phase, which is that letting go phase. which usually last about 10 days to 6 weeks. Okay. Also in the 80s, she did, Ramona Mercer, another nursing theorist, did maternal role attainment. And she said that the process of being a mom can start before birth, and it could last for 3 to 10 months after birth. Okay. And this is how the mom learned mothering behaviors. And she went ahead and she talked about anticipatory stage. When that mom looks for examples to follow, that's during pregnancy. Okay. That could be from a sister, that could be from her grandma, that could be from a best friend. Okay. Anybody that's close to mom, she's going to look for examples to follow. And then there's that formal stage where the mom acts as others expect her to act. And that's usually postpartum, and that's usually after postpartum for about 6 to 8 weeks. And then she goes, and that's when she says, yes, yes, and she takes it all in, everybody's saying, burp the baby this way, yes, yes. And then she starts to figure out different ways of doing it herself. Okay, that's why getting all this, her activities of daily living organized with a routine. It takes a couple of weeks, okay, 6 to 8 weeks. And then she starts to go into this informal stage where mom develops her own style. Okay, now she's going to begin to make her own choices. And then it's that personal stage. Mom is comfortable with herself as being a mom. Okay, and most moms usually achieve this by like 4 months. Sometimes it takes some moms a little longer, but usually they achieve this for about 4 months. And also in the 2000s, again, there is that process of becoming a mom, according to Ramona Mercer. And she did replace this with her theory from the 1980s. And she said, it is a process of becoming a mom. How you become a mom has new skills. There's an increased confidence in yourself. And this is going to happen as that new mom meets new challenges in caring for her child or her children. And then she went ahead and she said these are going to be in stages. And she went through the commitment stage, which is attachment to that unborn baby. Then she said there's an acquaintance stage where there's the attachment, but then you're learning to care for that infant. And then there's this new normal stage of now it's my baby and me. This is the new normal. It's not just me anymore. And then you've got the final stage, which is that maternal identity stage, which is redefining, herself to incorporate motherhood. Okay. And then we have engrossment. We have to leave something, for the boys. We talk about mom all of the time, so we have to leave something for the boys. And this is that father's absorption, that preoccupation, that interest in the infant. Great to see that when you see that in the labor room. And then about 80% of American women go through something called postpartum blues. Okay, this is usually postpartum, could be the first day till about 2 weeks of mom delivering, where she feels she's got feelings of emotional. She's crying. She doesn't understand why. She's got difficulty concentrating. She's irritable. She's tearful. She's anxious. She's fatigued. She's sleep disturbed. This stage of postpartum blues. This is normal. This is temporary, and this is self-limiting. Okay, this is a state that will generally pass within 2 weeks from delivery. Okay, there's some coping. Okay, and it seems like it's yes, I know that, but when you're going through this and you're overwhelmed, and like this mom that we're seeing that has a little 2-year-old or 3-year-old and now has a newborn and is home by herself, and she's trying to do all of this, coping, just the little things that will help her, like rest, when the baby sleeps, take a nap. You want to get help. Okay, you're not super mom. If she's breastfeeding, she's got to be patient. We'll recommend her doing something for herself, going for a walk. Okay. plan a day out of the house, maybe, a mall with her baby. I know here now in the 2020, we've got COVID, but there's, malls that you can go with your baby. You could still go and eat with your friends. If you have, everybody will offer the help, and sometimes the moms won't get the help because they think they're super mom, but then they're overwhelmed, they're anxious. So get the help, and leave the baby for a couple hours. Okay. There's also community resources that are wonderful for breastfeeding, and they're called La Leche League. LALECHE, La Leche League. They are wonderful, and they will sit on the phone with you. They will help you. They're obviously online, and they've got community mental health services they can refer you to as well. As we go into from postpartum blues to becoming a postpartum depression, there is that Postpartum Support International. So it's www.postpartum.net. And this, it tells you that mom's experiencing depression or anxiety. This is a great referral for them for postpartum depression, because this could be a tremendous stressful time for a family. Okay. And many factors are involved in a difficult postpartum adjustment period. Again, we went through that, sleep deprivation, financial stress, grieving over an unexpectedly difficult birth, traumatic family history, high expectations of the mom. I mean, the list goes on, but there is support out there for moms. Okay. And, my recommendation is always, when we do postpartum, we do discharge from postpartum, we give her a list of resources. We give her the phone number. If you need anything, call us. And that's always good, because that's that connection that she's got to, let's say, the hospital, the nursing unit, so that there's somebody that she can actually call, and then we can talk to her on the phone. We can tell her, we will say, do you have somebody you can call to pick up the baby, to be with you, to give, to offer you some help. So that is the best that we could do for them. And every time that we discharge them, we will talk to them. We will make sure that she's going home with support, that she has support. That's where our assessment skills come in. And that is also where our wonderful social workers come in. Okay. Because if she doesn't have the support at home, they will work on getting her support. Okay. And giving her different ways to deal with getting her support. Okay. And then, of course, this is your postpartum assessment. Is pretty much what we just went through, focused postpartum assessment. Okay. And then breastfeeding. Can't do postpartum without doing breastfeeding, because breastfeeding is all this baby needs for the first 6 months of life. We've got colostrum. Colostrum is a natural laxative. It's got protein, it's got immunoglobulins, and it's all this baby needs. So even when mom starts breastfeeding this baby and it's thin and it doesn't seem like it's a whole lot, it's colostrum, and it is what the baby needs. Okay, and then of course the milk comes in, and then you can start breastfeeding. Now, if mom is not breastfeeding, menstruation will begin in about 6 to 10 weeks. Okay. And if she's breastfeeding, menstruation usually begins in about 3 to 4 months. Sometimes it even takes longer if she still continues to breastfeed. Okay, so if she's not breastfeeding, she'll get her cycle back in about 6 to 10 weeks. And one thing I do want to mention and remind patients when they're breastfeeding is that it is not a form of birth control. Not a form of birth control. So we'd like to see her back. We don't want to see her back so quickly that she's going to get pregnant right away again. Okay, so just to keep in mind that once a placenta is delivered, the effects of estrogen and progesterone are no longer inhibit that follicular stimulating hormone. So what happens? Ovulation begins. Okay, So if mom is not breastfeeding, menstruation usually begins in 6 to 10 weeks. So it's great education to tell mom. And if breastfeeding, menstruation begins, may return in about 3 to 4 months, or sometimes may take even longer. So a little bit on breastfeeding. You have the slides, proper breastfeeding positions, latching on. We've got our wonderful lactation consultants in the unit that we will use. We'll work with mom to get her to breastfeed, to get her to relax and breastfeed. And there's different positions that we can have mom to breastfeed as well. And this mom is holding this baby, but if they fall asleep, you can take the little onesie off, just leave the baby with their diaper. You can have them breastfeed. Now you don't want to suck on the nipple. You have to suck on the areola, okay? So that you don't get that nipple breakdown. Some key points, and they're there for you on the slide. We provide teaching and counseling to promote that women's feeling of competence and self-care and baby care. Nursing plan of care includes assessments, comfort measures, and safety measures. Common nursing interventions, evaluating and treating the boggy uterus and the full urinary bladder. We provide for pharmacological and non-pharmacological relief of pain and discomfort associated with that episiotomy and that laceration. And then, of course, we institute measures to promote or suppress lactation. And if mom does not want to breastfeed, she's going to leave those breasts alone, okay? She can wear a binder, she can wear a bra. Okay, when she showers, try to avoid that hot water on her breast, because then she'll again start to leak. So maybe not put warm water on her breast when she's showering, and just leave the breast alone, okay? And eventually she will dry up, okay? And she will start to leak the milk. We don't give anything else to mom. We tell her to support her breast, wear a bra, a binder, okay, a bra, supportive bra, and we leave them alone. And meeting psychosocial needs of new moms involves planning care that's going to consider the composition and functioning of that entire family, okay? Effective means to prevent crisis and facilitate physiologic and psychological adjustments are used in combination. And there could be, follow-up visits. Right now with COVID, that's a little bit more challenging, but we could, you'll see follow-up visits, you'll see a telephone follow-up, support groups, referrals to community resources, and the hospital is great in the discharge planning, promoting, okay, facilitating, okay, for physiologic and psychological adjustments for mom. Okay, well, thank you for watching. Okay, thank you for listening, watching to your slides, listening to your postpartum lecture.